Good evening, everyone, and welcome to tonight's webinar. My name is Dr. Howard Golan, and I am coming to you live from New York, Long Island, and there is a large thunderstorm going on outside right now, so hopefully we won't lose power, but we'll continue on and talk about caries detection and visualization in dentistry and in the mouth with a novel product called the Camex Triton, and talk about caries detection and where we are, where we were, and where technology is today. So this was a post that I just found on Facebook a couple of days ago, and it's an interesting post because we see this all the time. And here, the poster said that number 20 distal occlusal was put on watch in September of 2016. For whatever reason, they put it on watch. However, if we look at the mesial of 19, or for those of you international viewers, 3.6, you can see that the mesial, there might be something going on there. Not really 100% sure, but I would venture to believe that because of the caries history of this patient, that there are something going on the mesial of that tooth. And lo and behold, nothing was done. Patient didn't come back. That watch turned into 2+ years, and significant caries lesion developed in that spot. And this is something that we see all the time. This is something that happens all the time, and caries diagnosis on radiographs tend to be very challenging. So with the advent of digital X-ray technology, certainly we've gotten better, and it is a little bit easier to diagnose decay because we can manipulate the film, we can manipulate the radiographs, we can do things that we never was able to do before. But there are still question marks. We know that it takes a certain amount of tooth structure removal to see interproximal decay. And so if we focus on these radiographs in the lower left quadrant, and specifically if we look at the premolar, and if we look really closely, this premolar here, is there something going on here? And I always found in my 20 years of dentistry that sometimes you look at it and it doesn't look like anything, and then you turn away and you come back and it looks like there's something there, and sometimes it doesn't look like there's something there, and it's a very big challenge sometimes for us to determine whether we have interproximal decay or not. And so wouldn't it be nice if we had something that actually showed us that was more accurate than a radiograph to show interproximal decay? So look here now, this is that same tooth. So if I go back to that slide, you can see this is what we would do. Now, there are plenty of you that would look at that and say, I can't really tell. Maybe we'll watch it and wait and see if it develops. But look here. There's something going on here, isn't there? There is decalcification going on there. There is a change in the enamel tooth structure that needs to be dealt with. And this is the visualization now that we can see with certain technologies that we never had in the past. And it provides us an ability to see the mouth and then provide for our patients, get to things early, and really change the way we deliver treatment and diagnosis. So tonight is about, for me, the concept of nature and the concept of technology and the concept of architecture and engineering and how all those things intertwine with one another when we're looking at teeth. Over the last 20 years, my philosophy has changed. I have really gone from a drill and fill dentist to trying to be as proactive and as minimally invasive as possible. What you see here, for some of you who know, this is falling water. This is a house that was designed and engineered by Frank Lloyd Wright, a very famous American architect. And this is in the Allegheny Mountains, and this was somebody's vacation home. It's a pretty spectacular place. I happened to have the opportunity to visit it last week, and it is an amazing architectural feat, because what he did is he basically built this house as an extension of nature. So when you can see from the outside that it's built into the rocks, it's built into the waterfalls, it's built around it, as opposed to excavating and sticking a house on the side of a hill. If you go inside, and this is one of my favorite parts of this house, is you can see this is a fireplace, and if you look down here you can see all of these rocks. Well, these are natural rock formations, and he built the house around it. He set the stone, he set the rock floor, so here is the floor, and here is the actual rock formations that were on this hill. And he built this house as a seamless transition from nature to the house. But his architecture was so well known, but it also, from what I learned, was very, very, very not as critical about his engineering skills. And a lot of his houses had engineering faults and problems over the years. And he took his designs at the expense of engineering and stability and things like that. So it's important that when we look at teeth, that cutting cavity preparations in a tooth, working on teeth as clinicians we do every day, it's important to know that it's not as good as your natural tooth. So if we look at this lower left molar, second molar, or tooth 3-7, you can see a very large composite restoration, and you see absolutely zero decay in the interproximal on this tooth. This tooth has a regular restoration. But if you look at it clinically, this is the distal marginal ridge. You can see that crack. And I have found over the years that many clinicians, especially younger clinicians, don't really recognize cracks and fractures in teeth. And they look at this thing, and if it doesn't show decay, it's not moving, they leave it alone. They don't touch it. And this patient has seen a clinician for many, many years, and this was never dealt with. Well, when we finally look at these cracks, we know that these cracks open and close. We know bacteria can get through them. And if we, and here's the other side of that tooth. Here's the mesenal marginal ridge, and there's another crack, right? And bacteria is getting through there. Now, it may not show up on the x-ray, as we see here. There's nothing going on here, but we do see it when we start removing this tooth structure. And you can see how those cracks start to inhabit the dentin. And once that bacteria gets into dentin, it starts to invade the pulp. And you now start to think about the cycle of death of this tooth. And so one of the things that I have found in my practice over the years is we are much more successful when we get to things early. We are much more successful when we keep teeth alive, when we don't create cracks and fractures, when we don't allow bacteria and cracks and fractures to get to the nerve, and we minimize the amount of endodontics that are done on teeth. And that's what we've built our practice on, and a lot of clinicians are starting to understand the value of early intervention and crack prevention. But it's hard sometimes to visualize what's going on underneath. It's hard for an insurance company to appreciate this, because if you sent this insurance company this radiograph and you said, I wanted to do a full coverage restoration on that tooth, they would probably deny it if you pre-authorized that, or even if you did it and sent it in, because there's no evidence on the x-ray. So of course we have to take photos. We have to see things visually. And the more we can show insurance companies and show patients visualization, the better. So as we start prepping this tooth, you can see that we can seal it, we can remove those cracks, we can start to support that tooth structure in a much better way. And I think we can do things better for our patients. So the question becomes, and I ask clinicians this all the time, are you proactive or are you reactive? Do you see a hole and fill it, or do you try to prevent holes from happening? And if you see holes, do you deal with those holes when they're small, or do you wait for them to get large? And do you prevent bacteria from getting into teeth as best you can, or is that not as important to you? Because it's important to me to be proactive, because I feel that's really important for the patient and for our practice. So Machiavelli, who wrote The Prince in 1513, said this, and what physicians say about disease is applicable here, that at the beginning a disease is easy to cure, but difficult to diagnose. But as time passes, not having been treated or recognized at the outset, it becomes easy to diagnose, but difficult to cure. And we see this all the time. We see small little things become larger little things, many times because patients won't do the work that we tell them to do, because they don't understand it doesn't hurt me, so why should I do it? We get that. I had that 3 times today. And we had to explain to patients that teeth don't always hurt when there's a problem, do they? So these are things that we have to deal with. And early intervention becomes a very important thing. So tonight, we're going to talk about caries diagnosis. We're going to talk about minimally invasive dentistry. We're going to talk about this product called the CamX Triton. This webinar is sponsored by Air Techniques, so thank them for doing that tonight. And throughout this, we're going to talk about the impact on return on investment. So I show this all the time because we see this all the time, and we don't really spend a lot of time on caries diagnosis. There's a lot of lectures out there on, you know, implants and veneers and aesthetics and Invisalign, but do we really talk about caries diagnosis? In fact, you know, how many clinicians, or do you write a diagnosis every time you do a tooth? Because in medicine, when you have to put a claim in, you have to have a diagnosis code. In dentistry, we have a procedure code, but we don't have a diagnosis code. And so it's interesting that we don't diagnose very much. So the question is this tooth decayed or not? You look at this tooth and there's staining in that groove, and a lot of people have stain. There's no frank cavitation at all. The patient has 0 complaints. They're not hot and cold sensitive. They're not percussion sensitive. They're not biting sensitive. Under radiographic examination, there is absolutely 0 decay that we see on the x-ray. So the question is, if you're a hygienist, what's your diagnosis? What do you tell your doctor? What do you tell your patient when they come in and they look at this tooth? If you're a dentist, what is your diagnosis? Would you treat this tooth? How are you trained in dental school to do caries diagnosis? Would this be a tooth that is legitimately treatable? Is this caries or not? So is this decay or stain? If it's, we don't know, do we watch it? Shouldn't we have a definitive diagnosis as medical professionals? Shouldn't we be able to look at a tooth and say there's decay or not in the tooth? That would be right. That would be nice, wouldn't it? What does the research say? And if you tell a patient you want to drill this tooth, what are they going to say when it does not hurt them to begin with? Doc, it doesn't bother me, so why should I touch it? Well, you have all, and I am sure that everybody who has ever done caries on a patient, who has done caries treatment, anyone who has put a drill to a tooth knows that many, many, many times something that looks very small, very easy, tends to sometimes get very, very deep or very big. And the concept is that when you hit the DEJ, that caries starts to go laterally, and goes laterally very quickly, because now you're into tubules and fluid, and those bacteria can go very, very quickly. So the question becomes is, you know, is this significant? If you looked at that tooth and said to yourself, before I showed you this picture, I wouldn't touch that tooth, and that patient comes back a year later, you're going to see decay there? Is it better to treat this tooth now than a year later or 2 years later? What's the chances that this tooth starts to die in the future? Because the more you cut a tooth, how does it react to that restoration? These are things that we always have to think about. So the reality is clinicians need to get better at diagnosis. We all need to be better. We should be able to go into a tooth and say there's decay or there's not. There is not 100% definitive diagnostic materials out there to say, yes, there's decay, yes, there's not. There's always going to be error in the process. But I think where we are today in 2018 with some of the technology that we're going to talk about tonight has really changed the way we look at decay from an occlusal perspective and from a interproximal perspective. Clinicians need to get better at educating patients. And one of the ways you do that is you become more objective than subjective, presenting information to patients that is objective. It's very hard for them to dispute that. Whereas if you say, well, it doesn't bother you, but I think it's got decay, well, show me. I can't. That doesn't really help us. And we as a profession need to learn to be more minimally invasive. We need to cut less teeth. We need to preserve tooth structure, in my humble opinion. But in order to do that, we are taught that that's very aggressive. There was an article a couple of years ago in the New York Times about overdiagnosing in dentistry. Okay, insurance companies sometimes come back to us and say, why are you doing so many crowns? Why are you doing so many fillings? Okay, we are in between a rock and a hard place. It is very easy to be considered an over-treater. And so we need to show some diagnostic tools that allow us, just like in medicine, where we have markers like A1C and blood pressure and other things, we in dentistry need metrics, or at least visual metrics, to be able to show patients and show insurance companies and show our colleagues that what we're doing is true and what we're doing is important. Takeo Fusuyama, one of the godfathers of adhesive dentistry, really was instrumental in the development of dentin bonding, talks about caries treatment, that the determination of hardness by hand is an indefinite subjective matter and can never be an objective guide for caries removal. It is quite surprising that we as dentists have up to now performed caries treatment, our most important professional duty, while relying on such ambiguous means of detection which have no scientific basis. Interesting. Now in this article, he was talking more about how do we know that caries are gone from a tooth, which we'll talk a little bit about later. But it's important to really emphasize the fact that caries diagnosis and treatment is huge for us, and a lot of what we do is extremely anecdotal, it's extremely unscientific, and extremely subjective. And it's important for us as a profession to grow and get more objective. So, unfortunately, okay, pothole dentistry is still there today. And there are a lot of clinicians that, make a lot of money filling teeth and filling holes. And I do that. I mean, I see holes all the time. The problem with pothole dentistry is that there really isn't a philosophy there. It's basically see a hole, fill it, fix it, and when that breaks down, go to the next step, and when that breaks down, go to the next step, and eventually you need a root canal, and then you need a crown, and then that root canal might fail, and then you may need an implant. It's this cycle that really doesn't have a true philosophy to it. As opposed to being minimally invasive, trying to prevent decay, trying to prevent cracks and fractures, really to me is where the profession needs to go. So there has been a significant evolution in caries diagnosis and treatment. The original concept was take an explorer, stick it in a hole. If it sticks, go. Okay, fill it. All right, and then over the years, we realized that just explorers are not enough. By looking at it, we can create some visual scales to help us look at things. But what we do know is that dental restorations have a limited lifespan, that the intact tooth is better than cutting that tooth, that restorations are never as good as a natural intact tooth. That the original concept of preparation design was that amalgam fillings, which is what they were, what the preparation design GV Black concepts were for, required a lot of tooth removal for convenience form and resistance form and outline form, and this concept extension for prevention. Right? And that evolution is now starting to change, where we know, now with composite dentistry and adhesive dentistry and sealants and early intervention and all of the preventative measures that are out there now, we're starting to change the way we look at teeth, and we're starting to get to things at earlier. Prevention is a huge part of our practice and very important to educate our patients. So we know now that teeth can remineralize, that in the right circumstances, that when there's minimal tooth structure loss, okay, that enamel decalcification has the ability to remineralize. Or we can halt the disease process with things like infiltration, like resin infiltration, like the Icon system. And once into dentin, caries will progress while the enamel stays intact. So we can see remineralization at the surface of the enamel, and yet at the DEJ and below, caries is progressing. And so visually, teeth do not look what they used to look like. So caries can progress during the subsurface, while the occlusal surface of the tooth looks okay to the clinician. And it's essential then that we have an ability to see the extent of a carious lesion to determine when to restore and when to attempt to remineralize. Because if I can get to a tooth early, if I can keep that, if I can see enamel demineralization like interproximally early before it shows up on an x-ray, then I know that if it's in enamel, I can at least infiltrate it and have very good success. So it's important that we have good diagnostic tools to get to these teeth in an early manner. So early intervention, looking at things, looking at stained grooves and deciding from as soon as that groove is stained, do we explore it, do we seal it, do we enamelplasty it, do we take it out of the potential? Okay, increasing an objective diagnosis, trying to understand the subsurface occlusal diagnosis, where it looks okay on the surface of it, but it's actually decaying underneath. Being able to use less radiographs and not have to struggle so much to diagnose interproximal decay, and therefore extend visually in the mouth. So being able to take pictures and cameras and being able to see what's going on interproximally, what's going on subsurface occlusally, what's going on deep in the mouth that we can't really see with a large field view of camera, but things like that. So visualization becomes super, super important. So early intervention, it's the goal of my office. It starts from day one. Every person in the office accepts it, promotes this philosophy. So the first thing my hygienist does, all right, is she asks the patient about, are there any sensitivity? Before she asks about their family, before she asks about where they work and how many kids they have, we're all asking the patient, are your teeth sensitive to hot, cold, biting, or sweet? We want to get rid of that stuff right away. We want to talk about that. We want to talk about the fact that we are an early intervention practice. We are going to find things in your mouth. You may not like it. You may not want to have it fixed, but we're going to find things. And we have a lot of cool technology tools to help you find things. Okay? And when we find them, we're going to get them early so that if you have little areas of decay, we're not waiting for that to get so bad that I have to cut more tooth structure. And I'd rather have a 1 millimeter filling than a 3 millimeter filling than a 6 millimeter filling than a 9 millimeter filling. And we want to get decay as early as possible and minimize the risk of future decay. And my philosophy and my tagline is enamel rules. Because if you lose enamel, you lose the integrity of that tooth. Enamel is the most important thing. Enamel is the most resistant to acid attack. Enamel is the aesthetics, it's the strength, and we want to keep that enamel as much as possible. As soon as we get to the DEJ, we're starting to take a lot of enamel away to remove that decay. So it's important that we keep enamel strong. And one of the reasons that I really got into becoming this, trying to transfer away from pothole dentistry, this was my wife's best friend. My wife's best friend came to me with a tooth, an intact virgin tooth with a groove, and these two, what I thought at the time in my young career was relatively developmental grooves, because that's what I was taught so many ways, that these are developmental grooves. Okay. And one day she came and she had pain to biting. I opened the tooth up and this is what it looked like. It was completely empty, not a single drop of nerve tissue, and you can see that that crack and fracture goes from one groove, which was really a crack, to the other side and through the furcation. And this tooth was hopeless. This patient needed an implant, and at the time she had no money to do an implant. And I said to myself, I wish I could have done more. I wish I would have known that this tooth was in trouble all those years ago. That maybe if I had gotten to it early enough, maybe I would have been able to stop those cracks from getting to the furcation. Maybe I could have done that. That would have been a wonderful thing. If I could have done that, it would have saved that patient a lot of money, a lot of time, a lot of discomfort. And so it's really important for me to get to things as early as possible. If you learn one thing from me tonight, it's the importance of conserving tooth structure. This is an article presented by Doctors Milicic and Rainey, who are, in many people's eyes, the godfathers of minimally invasive dentistry. And they talked about conventional cavity designs are disharmonious with the tooth's natural mechanical stress distribution system. The philosophy urges the use of modern methods of caries detection for early, accurate, minimal intervention in the caries process to preserve internal mechanical structures that are vital to its long-term mechanical stability. Which means is that if you look at a tooth from an engineering perspective, it is a marvel. It is an engineering marvel that the tooth has everything in that tooth has a purpose, that the tooth is interconnected with one another. And when you slice a box or you slice a groove through that tooth, you actually disrupt this it's almost like cutting the cables off a bridge. You're disrupting those engineering marvels, those intertwined teeth that are pushed together, and you're kind of springing them open, like those cusps are in tension with one another. And so what they're saying is don't cut teeth. And if you have to cut teeth, keep it small. And so their article is pretty interesting, and very special. And it talks about, and you really, after you're reading this article, you probably will not look at teeth the same way again. And that every time you cut a tooth, you will think about what you're doing to that tooth well into the future. So what do traditional cavity prep designs do to teeth? They can crack them. They can crack them. And we see this all the time. And you see teeth die all the time under restorations. And so it's important that we prevent these traditional cavity designs. This was an article that talked about the strength of teeth after prepared cavities. And the science justifies the notion that tooth preparations, even modern adhesive preparations, weaken the teeth compared to a virgin non-restored tooth. So if you haven't figured it out now, the big theme of tonight is get it early. Well, if you're going to get it early, you got to be able to see it. And if it's small, if it's subclinical, we've got to find ways to do it. So there's really four ways, and the fifth way is radiographic. But there's really four ways to diagnose occlusal decay, right? Obviously the Explorer, which was used many, many years ago. Caries detection devices, okay? Well, I'm sorry, caries detector dye, visual, and then the concept of laser fluorescence. And methods 1 and 2 have a very, very good, neither one of them, none of them are, 1, 2, and 3 are not wonderful for sensitivity and specificity. Sensitivity meaning avoiding false negatives, specificity avoiding false positives. Okay. Now you can increase those with higher magnification, but the reality is it's not enough. What is happening subclinical? Because the enamel, especially in today's world, Procter & Gamble, Johnson & Johnson, all of these companies are trying to provide better toothpaste, better mouthwashes, and we have the ability to remineralize enamel. We can do it, but we can't remineralize it really that easily. And so when we remineralize enamel, and there's decay underneath that, it's very hard to see. So we need something more, okay? Because stain pits and fissures tend to have caries in them. This is from CR reports, which used to be called CRA reports, and it's an old article, 1999, but it's pretty interesting that 92% of stain pits and fissures in non-smokers are caries. So there's no question that there's more decay than we think in these stained grooves, and thus what do, right? And we know that an Explorer is not that effective, and I think most of you would agree. So the limitations of traditional methods is mediocre sensitivity and extremely poor specificity, especially when the lesion is non-cavitated. Zero patient impact. It leads to inconsistent treatment plans and consistency in office treatment, leads to the progression of disease most of the time without symptoms, which leads to clinical implications and potential medical legal implications. And as somebody who has been an expert witness, I have seen cases of decay that was not diagnosed, that a patient went into an office, had a clean bill of health, some of the things were watched, and the patient comes back a year later and needs a couple of root canals in those teeth, and then went after the previous dentist, for not having them fix those teeth early enough. Okay. Now every state, every expert, every case is different, but these are things that you don't want to have to deal with as you move forward. So there's very little patient impact here, right? I mean, even if you take digital photos and you see these stained grooves, patient's going to look at that and say, okay, it's not so bad, doesn't bother me, leave it alone. And so I wonder if this has ever happened to you. Mrs. Jones, you have 7 cavities. That's impossible, nothing hurts. My last dentist I saw 1 year ago said I was fine. But Mrs. Jones, look at the stain around some of these teeth, the marginal breakdown. I need to fix those. Look at the stain in the grooves on the one on the right. Nice to meet you, doctor. See you later. 2 weeks later, Dr. Gold, I went to another dentist, and he said I have maybe 1 cavity, if that. Please send my x-rays to him. Well, that's the overtreatment concept. Well, what we know is that patients learn better visually. Patients absorb information that is presented in terms that is familiar to them, and patients appreciate minimally invasive approaches. And patients usually never fully appreciate the pay now instead of paying more later concept. So caries diagnosis, especially laser fluorescence, is a marriage of objective diagnosis and patient education. So now we have a method of caries detection that is much more objective. It uses LED technology to measure the caries' existence and magnitude and provides patient impact by showing them pictures. Okay? So fluorescence is the visible or invisible radiation produced when certain substances as a result of incident radiation of a shorter wavelength, such as 610 or things like that. So basically, why do caries fluoresce red? Okay. And what's happening is the byproducts of the bacteria. And what we're doing in laser fluorescence is we are measuring porphyrins. Porphyrins are a bacterial byproduct of acid attack. The more acid attack, the more porphyrins that are in the area. And that's what you are seeing here. So this concept and that light will excite the molecules, the electrons at the end of these molecules, and will create the fluorescence. And we don't have the time right now to go through the details and the physics of all this, but needless to say, you get excitation at one wavelength, and it gives off another wavelength of light, and that wavelength of light is absorbed into the camera, and the magnitude of that absorption then gets to a scale. And what's nice about these types of products is you can create a scale. So you have this intensity of light. The more you have of the absorption and excitation, the more it's going to register. And you will then be able to create a scale. And this is some of the physics and engineering that's involved in this. So this is a picture of a tooth that was shot with the caries detection device called the Spectra. And you can see that there is a value, there is a scale that they have developed where between 1 and 1.5 there might be something going on. And as you get bigger into the scale, you have more decay present, more acid attack. And so not only do we see the red, the blue, the green, and the yellow, but we also see a number. And so we call this Doppler 5000 to our patients, because as soon as they see that, they kind of know a storm is a-coming. And so it's very easy to get them to understand, well, this is what we have to do now. So there was many studies on the use of this, and one of the studies they did was try to find what number is the magic number. What number shows the best in avoiding false positives, and on the flip side, avoiding false negatives. And what they found was that 1.8 is really the magic number, that anything over 1.8 is going to be dentin decay, that there is going to be significant decay past the DEJ, 1.8. However, ladies and gentlemen, if you notice on the screen, it says 1.4 is the magic number, because we don't want to wait until it gets into dentin. We want to see 1.0, 1.2. We don't want to see 1.5, do we? Because if we see 1.5, then we know there is acid attack in the enamel. So what we do in our practice is we say to patients, if anything shows up 1.4, because that's really on the edge of the cliff, anything over 1.4, we are going to open up that groove and explore. And it's this exploration of the grooves that allows us to get to things early, because anything over 1.4, we know that there is acid attack on this, in this tooth. And so that's 1.4 for us in our practice is the magic number. How we restore it, how we finish it, is going to be up to your determination as your clinician. So here's a tooth with a lot of grooves. Great. Okay. No pain. I think everybody would agree that up here towards the distal of this tooth, there's probably something going on, but there's some stain here, not necessarily anything that's out of the ordinary. But when we shoot the Spectra on it, look at all of the 2.2s, 1.9s, 2.6s. That tooth has significant decay. And as we start to prepare this, you can see that we're starting to get into dentin, and this became a true class 1 cavity preparation because of the significance of the decay. So I always say to patients, we don't want to watch it because we don't want to watch it get worse. We know something's there now, and that's the power of this type of product. One of the interesting things about the Spectra, though, and we talked about it earlier, is having an endpoint for caries removal. And there's been a lot of studies on the use of laser fluorescence in caries removal. And so we use our Spectra as a caries removal device. So this is a lesion that we were doing, and there's some decay still present. But looking at it, and even with my Explorer, it felt pretty good. But when I put the Spectra on it, I still had 1.6 into dentin. That's too many porphyrins. So I took my round burr, cleaned it up a little more, shot it again, caries free. So from an objective, because the last thing you want to do is leave decayed teeth if you don't have to, right? So excellent for the use of caries removal. So that is the Spectra, okay? That is laser fluorescence going on the screen, showing you the colors, putting a scale on it, pretty amazing. In the past couple of months, we started to use this second aspect, which is what we talked about earlier of interproximal decay. We know that X-rays for caries is pretty high in dentin, with a high sensitivity and specificity. Because when it shows up in dentin, there's a lot of tooth structure removal that's involved there. But X-rays are not as good for early lesions of enamel because it doesn't show up as well. And so it's important to diagnose because we can treat early, as we talked about, with resin infiltration potentially. More and more patients are concerned about X-rays. So, how often do you take bite wings? Do you take them every year? Do you take them every 6 months? Well, how many times do you have patients say, I don't want X-rays? Well, maybe now we can say, okay, you don't want to take X-rays? That's fine. We're still going to use our proxy head, and we're going to look and see if you have any interproximal decay. Very important. And it also allows me to visualize cracks and fractures and show patients the crack and the fracture much more pronounced. So again, this was that first case from before, and we were focusing on here. And if you look at the distal of that, maybe you can see a little bit of a triangle, maybe you can't. I'm curious that if we put 20 dentists in a room and 20 hygienists in a room, looking at this picture, how many of them would say there was decay there? Honestly say there was decay there. Well, there's decay there. There's cavity. There is a carious lesion, maybe not into dentin, but certainly into enamel, and one where I can now infiltrate that instead of having to cut a box into that. That to me is pretty, very important. So the proxy head is illuminated with an 850 nanometer LED lamp. And it captures an image with a high resolution, and the images will display to having various translucencies of the parts of the tooth, with healthy enamel being the most translucent. So it really also depends on the water content of a tooth. And so it's not perfect. It doesn't work with amalgam restorations because the amalgam pretty much takes everything over it. But this is a pretty interesting product and one that's been a lot of fun. So let's look at this product. How many times do you see X-rays and you see some potential burnout here? What's going on here? Do you see anything on the distal of the cuspid? Do you see anything on the distal of the premolar? Is there anything going on the mesial of that premolar? Well, looking at it, based on the patient's caries history, well, maybe we could be more aggressive, but the reality is, diagnostically, I can't tell 100% that there's something going on. We see artifact and shadows all the time on X-rays. Well, when we shine that mesial of that second premolar, look what we see. And what you're seeing here is the proxy head at its best. the translucent enamel ring, that dark translucent enamel ring. This white opaque dentin is here, and then you have this carious lesion. There's nothing on the mesial in this view, but there is on the distal. And I want you to understand this is a dynamic picture, is that you're moving the head side to side, left, right, up, and down to get all different angles. Then you're pushing a button and creating a screenshot. It is a very, very easy thing. And what's amazing about this product is that it's a different head. All you do is take the head off and put a new head on. You don't have to unplug the whole camera and things like that. So what's nice about the CamX Triton from Air Techniques is it gives you 3 different heads. It gives you an interproximal head, it gives you the Spectra head, and it gives you a wonderful intraoral camera. So again, if we look back here on the mesial of this second premolar, I don't see anything. Maybe there's a little overlap, I'm not sure. But when we put that proxy head on it, done. There we go. And you will diagnose a lot of caries. And when you open it up, that's what you see. Now, the question is, why did I infiltrate this one? Well, I was worried that it was starting to penetrate into dentin. Okay? And you can see how significant this is, because here's the DEJ right here, and there you have your decay. Okay? Here's another case. Very different looking teeth. Patient is a significant bruxer, but again, what does it look like? So every time we see these patients now, we're putting the proxy head on them to check their interproximal. It doesn't take very long to go through and check all of the interproximals. There's the molar. You don't really see much going on. Maybe there's a crack there, we're not sure. But when we shine it, there we go. Kissing class 2s, done. Notice, again, see the interproximal, see the opaqueness. This is the caries. So it gives us and this was a holistic patient that didn't want to take x-rays. So this is a great product to allow us to see things that we really didn't get to see before. Okay. Here's a case. Now the amalgam is going to really ruin this, but what I want you to look at is the I wish that I had something. And here's pretty easy to show a patient. Well, look at the opaqueness here versus here. And you can see that the reason this looks like this is because both of these fractures right here are preventing the light and the water from getting through, and it's changing the integrity of that tooth. But this patient then has a lot of other stuff, right? So if you look here, because of that, look at how the amalgam turns it all dark. So it's really not great around amalgam. But let's look at this right here. Right? Look at the cracks and the fractures, right? Does that patient impact if I blow this up and they see this? Are they going to go crazy? Are they going to let me do something? But when I shine the interproximal head, look at how much more dramatic that crack is now. Look at the discontiguousness of this tooth, part of the tooth versus this part of the tooth. So even though there's an amalgam, even though I can't see what's going on necessarily in a proximal, I can show a patient that fracture line and say, hey, look at what that fracture is doing to your tooth. The visualness is showing us something. So the advantages to clinicians are objective tools for caries diagnosis. You can limit the amount of bite wings. Okay, we still need bite wings for perio. We still need bite wings as a medical legal concept. We still need bite wings as an overall view, but certainly the recall bite wings, the patients that don't want to take them every 6 months to a year, I think this is a wonderful tool to help us avoid some early decay misses because of patients wanting to do it. We can diagnose early and treat early. And yes, as a business owner, I'm diagnosing more stuff. I'm doing more dentistry. But I have no problem doing more dentistry from an objective test. I don't have any issue doing that. And I don't apologize for doing a lot of dentistry on my patients when they have problems. Supplement questionable lesions on x-rays. Hey, I don't like the way that you look at this. The x-ray is not 100%. Let me put this proxy head on and see if I see it. If I don't, that's great. The other thing that's very interesting, and besides the crack diagnosis, which is very interesting to me also, is the concept that when you're doing, like, let's say an MO bead onlay on tooth number 19, what I find sometimes is you do that, and then maybe a year or two later, you have to treat the other interproximal. Well, what I'm doing now is I'm making sure that before I do the one interproximal on one tooth, or I'm cutting tooth structure on one side, I always check the other side to make sure that there's nothing brewing there, so I don't get stuck and I have to do two different restorations down the road. And what's nice about this interproximal head is you have the ability to now have a nice HD camera with it, a nice spectra which gives you the occlusal caries, and it's really a special product, and I hope that I have shown enough of that. But where it really comes into play is obviously the hygiene room, because this is where the money's made. The hygienist is capturing and already starting to talk with the patient about the findings before we ever walk into the room. My hygienist, Tori, she is a spectacular hygienist, and she's educating people from day one on cracks, on fractures, on early intervention. It's easy to use. It eliminates the bite wing debate. Mrs. Jones, you don't want to take x-rays today? Fine. I'm going to put the proxy hat on. Not an issue. But at some point we got to do them, but you don't want to do them this time. I get it. Let's go. We're not fighting them anymore with that. And the Spectra and Triton can be used to monitor lesions as well. Because I'd rather say I love to say to patients, I told you so. So if I can tell them they've got something and they refuse to do it, at least I have a baseline. At least I have a record of it. And if they don't come back in a year and fix it, and it's not my fault, I've got it diagnosed. So really increasing the diagnostic process is something that has made this very different. So in conclusion, being able to do visual, being able to do occlusal, being able to do interproximal is what I and my hygiene department do every single day. That camera is out every single day, working in the hygiene room, working in the operatory, allowing us to see things at a much higher level. We're maximizing patient impact. We're not fighting patients anymore. We're getting patients to not as much. We're not getting patients to reject caries treatment as much as we had. And we're getting the early intervention ball rolling. And for everybody, I think we all would agree that knowledge is power. So with that, we've got about 7 minutes left. I hope you had a wonderful, I hope you had a good time. I don't want to say wonderful, but a good time. I hope we're teaching about what we're doing. And if anybody has any questions, please type them in and I'll be happy to answer them. I'll be here for a couple more minutes if anybody has any questions and they want to ask me. Again, please type them in and I'll see if I can get to them. But again, what's important is early intervention, teaching patients about their mouth and about what cracks and fractures and decay can do to them, and getting to things early. If you have any other questions, please feel free. Can you repeat the name of the cam? Yes. So the name of the camera is the Cam X Triton. Cam, C-A-M-X Triton HD. Now, I want to be clear, there are other products on the market that have some similar functions, but what makes this camera pretty spectacular from Air Techniques is the fact that there are interchangeable heads that go on a single base, and that really is amazing. I don't have a picture of the Camex Triton for those who ask that, but you can look that online pretty easily. What is the difference between the Diagnodent? That's a really good question. Diagnodent also uses porphyrins. Diagnodent uses a number system as well. What Diagnodent doesn't have is they don't have visual. Okay, so basically Diagnodent takes a reading, comes up with a number, and you decide what number it is. And there's been some debate over the years as to which number we should use. And you have to write down the numbers, and each part of that groove has a different number. What's nice about the Spectra part of this is it takes one picture, as you shown, a picture of the tooth, and it maps it all out in one thing. Whereas Diagnodent, you have multiple numbers in each part of the tooth. And how do you keep record of that? So I used to use Diagnet. It's got the same concept as Spectra in terms of measuring porphyrins, but I think that this is a much more robust patient impact device. Is the unit portable or cordless? It is a USB plug and play. You put it into your, they have their own digital X-ray plug and play software. You can use your own and bridge it into your own. And it's corded, but again, each of the heads is interchangeable on the same base. So you have 3 heads. You have the HD camera, you have the Spectra, and then you have the interproximal head. Do the images get stored for comparison later? You can do whatever you want. You can label them, you can put them in a comparison. We just take a picture and label what tooth we're taking, and so we can look back on that down the road. Obviously, the next question becomes cost of the unit. That is not something that I'm going to address. If you want to address that, you can contact Air Techniques, and they can give you an answer to that. Another question, do you charge a fee for the use of the Spectra? The answer is absolutely not. The use of the Spectra is a diagnostic tool. It is an investment for me and the patient, and I overwhelmingly pay for that Spectra easily every day with the amount that I diagnose and the amount of dentistry more that I do. So could you charge? I guess, but I don't think that that's necessary when you're diagnosing that much. Does your practice place sealants on adults regularly? Well, that's a good question because most insurance companies do not pay for adults sealants. I agree. So what we do is we say to patients, look, this is not a covered expense, but a sealant fee, and what I mean by sealant on adults is anything that stays in enamel. So if we have a 1.4, 1.5, we open it up and it stays in enamel and I don't have to touch the DEJ, we will call that a sealant and we will charge the patient less than a class 1. And most patients will pay for it because it's a smaller fee. It might be $20, it might be $30, something like that, as opposed to what a class 1 cavity prep would be. So yes, it doesn't cover sealants on adults, the insurance company, but we make the fee reasonable enough that patients are willing to invest the money. That's a good question. Any other questions? I don't think so. So at this point, I'm going to end the session. I want to thank everybody for joining us tonight, and hopefully you can see the value of caries detection devices like the Spectra and the Proxy Head in your office. Thank you, everybody.